Okay, so welcome to today's webinar. Today's webinar is laser therapy for adhesive capsulitis, or commonly known as frozen shoulder. Earlier I mentioned if you could hear me or not. Most people say that you can actually hear me, so that's good. A few little housekeeping items. If you have any questions, please type them in, and I'll address the questions at the end of the webinar. As well, if you have any difficulties tuning in or have to leave or what have you, you can watch the webinar in entirety when it's reposted on our support page within a week. Okay, so let's get started. I wanted to welcome everyone to today's webinar. Sorry, I'm just doing a few little things here. I was really surprised, and actually it's a really good trend. We're seeing a lot of people, both our BioFlex users and some new people that might be interested in joining up for these webinars. And this webinar, we have over 300 people registered and tuning in today, so that's a great number. I really do hope the content meets your needs and that we can work towards getting people better. So I'm going to talk about some fun facts about adhesive capsulitis that you may or may not know, just kind of interesting. Research article, and specifically a recent research article that talks about what may or may not work for frozen shoulder. Then I get into a bit of the pathophysiology, not too in-depth, along with a Cochrane review that's really important for us laser therapists out there. BioFlex treatment approach, so I can give you some guidance on how we approach treating along with a case study to go over some of the parameters that we've used. This case study is a patient that's attending right now, so it's very current, so I thought that would be a good topic to go over as well too. And then I recently attended the NALT, which is a North American Association for Photobiomodulation Therapy in San Diego a couple of weeks ago. I had the pleasure of meeting Andre Mester's son, who's a physician in California, and I wanted to talk a bit about that. So I thought you guys would find that very interesting, along with a research update that is very, very interesting with respect to lower back pain. So that's what we're going to do today. Let's start off the day, of course, with frozen shoulder. And what we have here, obviously, is a little igloo on top of someone's shoulder, and I thought that was kind of a funny way to put it, but indeed frozen shoulder is a very common problem that a lot of people will go see their physician about, and they'll typically prescribe medication and tell them to go for some physio or what have you, but at the end of the day, they typically don't know how to manage these cases very well. So we know the incidence is relatively high. In the general population, it's about 3%, which actually is, when you consider it, many people that are walking around with frozen shoulder. We know that it tends to be more common in the age category of 40 to 70 years of age, with females being more common than males. It definitely is more common in diabetics or pre-diabetics, oftentimes to do with circulatory issues. Typically unilaterally, however, oftentimes it will then predispose to developing on the contralateral side as well. Pathophysiology is poorly understood. However, they know that the capsule undergoes hyperplasia, or sort of increased growth, and fibrosis. So they know that that's part of the whole process. Pain is usually very common at the beginning, tends to decrease over time, but it can persist, especially the decreased range of motion for a long time. So you need to understand the pathophysiology in order to properly manage these patients. And oftentimes there's no known causes or triggers, and I'm going to talk about that shortly. You should also be aware of the potential differential diagnoses or alternative diagnoses for patients coming in with reduced ranges of motion, that kind of thing. I won't spend a lot of time on this, but of course you have to rule out things like AC joint issues, autoimmune disorders can play a role, biceps tendinopathy, cervical disc degeneration and radicular pain in and through the shoulder. Of course, neoplasm in and around the shoulder can be an issue. Most commonly is rotator cuff tendinopathies or impingement syndromes, with or without impingement syndrome, and bursitis around the shoulder. These can all lead to shoulder pain and decreased range of motion. So we need to know what we're dealing with. Sometimes there's multiple things going on, like rotator cuff tendinosis or tears, along with frozen shoulder. That's the case I have presenting later today. So we know that there is inflammation, especially in the acute phase, the beginning stages, and that leads to thickening of the shoulder capsule. And this is why laser therapy can be very beneficial in treating these patients, because it's going to address both of these issues. It's going to address the inflammatory issues because we know now through a huge body of evidence that light therapy increases white blood cell activity and the numbers of white blood cells, and they help to modulate the inflammatory process by increasing anti-inflammatory mediators and decreasing pro-inflammatory mediators to help control inflammation. That's well understood, and one of the main reasons why you would be using laser therapy in these types of cases. Secondly, when you talk to about the actual shoulder capsule and the fibrosing, we know that the type 1 collagen normally found that is predominant in a capsule, that over time with a adhesive capsulitis, you start to get increased type 3 collagen, which is a looser, not looser, but more haphazard and not as well aligned type of collagen, and it tends to increase in these patients. We know that laser therapy actually helps to increase the amount of type 1 collagen as a percentage from type 3, and it stimulates collagen production. So it's actually very beneficial to help modulate and turn over the collagen, the excessive collagen production that's type 3, into more mature and better collagen of type 1 over a period of time to help with the fibrosing. I thought this was a really good chart. It's taken from, you can see at the very bottom there, the natural history of frozen shoulder syndrome. And at the very top, it goes over the etiologies from primary idiopathic, unknown etiology. I mentioned about some of the causes like diabetes and so forth. And then there's secondary, which is less common. That tends to be from prolonged shoulder injuries or microtrauma. So it could be secondary to surgery or rotator cuff tears, fractures, and so forth. And oftentimes, you tend to see this developed in patients that have had stroke or hemiplegia that leads to decreased movement of the shoulder, and that can trigger frozen shoulder as well. Okay. In the first stage, which they say, generally speaking, lasts 2 to 9 months, this is more the inflammatory phase. You have a lot of inflammatory molecules being released. It would obviously trigger pain. The pain tends to be more diffuse throughout the shoulder, significantly worse at night, and oftentimes disabling because they can't really lie on the shoulder very well, and this causes ongoing difficulties. The second stage is into 4 to 12 months, approximately. The inflammation is slowly starting to resolve. That's helping with shoulder pain, but now we're getting more fibrosing and fibrotic scar tissue formation that leads to joint capsule issues, especially increasing in shoulder stiffness and progressive restriction in shoulder movement. This tends to be a very stubborn stage that a lot of practitioners finding difficulties getting their patients out of this stage and progressing through the third stage that can last up to 24 months, where you start to get the scar tissue, again, accumulating in the glenohumeral space and thickening, contraction kind of scenario, and you're definitely getting issues with both active and passive range of motion. So this is important that you have to really work on this manual therapy as well too to help with movement. Okay, so moving on, this is a paper I want to mention about the effectiveness of physiotherapeutic interventions for the treatment of frozen shoulder. So it's looking at the current best evidence of the use of physical therapy interventions. Fairly recent article in the Journal of Back and Musculoskeletal Rehabilitation. They looked at 39 articles that analyzed, that were looking at frozen shoulder using Sackett's levels of evidence, and they made the following conclusions: that therapeutic exercise and mobilizations are strongly recommended for pain, range of motion, and function, especially in patients with stage 2 and stage 3. So this is really important because when a patient presents in an acute stage 1 frozen shoulder, you're very limited as to what you can do therapeutically with manual therapy. That's where laser therapy is really critical to do that initially, because you can reduce the inflammatory exudate and get them out of that stage 1 into the stages 2 and 3 much quicker, and help with ranges of motion and so forth. They concluded that low-level laser therapy is strongly suggested for pain relief and moderately suggested for improving function, so that was quite good. They did recommend corticosteroid injections in stage 1 frozen shoulder. Obviously, I'm not a big fan of corticosteroid injections. I think this is more effective, but they're showing some evidence that it may be helpful. Acupuncture is also moderately recommended, so that's good. Electrotherapy was not or minimally recommended. I can't remember now. I may have made an error there. It may have been minimally recommended. Passive range of motion is recommended for short-term pain relief only. Deep heat may also be helpful, and ultrasound is not recommended. So that's what the current evidence is suggesting. Now, even more current evidence, this is only a couple years old, is the Cochrane collaboration on electrotherapeutic modalities for adhesive capsulitis. And they concluded that overall, based on moderate quality evidence, which is very good, laser therapy, it probably is effective adjunct to home exercises in terms of pain, up to 4 weeks, and function up to 4 months. So Cochrane collaboration actually had enough evidence to support the use of low-level laser therapy for frozen shoulder. This is really important because when it comes to insurance coverage, especially for our friends in the United States, that when you're fighting for coverage that you have a bit of leeway, you can pull up these Cochrane collaborations and the other evidence, and hopefully they'll agree to pay for laser therapy based on this type of evidence, which is very high. What's really interesting about this Cochrane collaboration is that they were not able to conclude any other electrotherapeutic modality was effective for frozen shoulder. So in other words, insurance might cover ultrasound or TENS or what have you, but in reality, the evidence, the current evidence is suggesting they're not really effective, okay, whereas laser therapy is. So if you're not using laser therapy, if you're just kind of tuning in to see what laser therapy is about, that kind of thing, the evidence is definitely starting to be a lot stronger with respect to using it for many conditions, including frozen shoulder. So now I want to talk a bit about our approach for treatment of a frozen shoulder. It's slightly different than in a standard shoulder protocol. The first placement that we do of our array is over the anterior aspect of the shoulder, trying to get the anterior shoulder capsule. You can see there's red light on right now, but of course that will turn over to infrared after that red light is finished. The next placement is going to be lateral placement, again trying to treat over the lateral aspect of the joint capsule and the surrounding tissues. And then the third placement is a posterior aspect, again over the posterior aspect of the joint capsule and surrounding tissues. And we do add an extra placement in the axillary region to try and promote light therapy in and around the inferior aspect or the axillary aspect of the joint capsule. So we do add an extra placement. It's a slightly longer treatment. Remember that these arrays are trying to promote the anti-inflammatory effect mediated by the blood and interstitial tissue. So these LEDs and these arrays aren't going to drive light really, really deep because they are LEDs, but what they are really and what they're aiming at is to increase the blood flow and the activity of the white blood cells that will be circulating in and around the joint capsule, and that's what's going to help the most with inflammation and the repair of the fibrosing and scar tissue in the shoulder joint itself. Okay, that's really important to understand. If you're just going to use a laser probe over the actual joint capsule, you will have some effect, but you won't mediate the anti-inflammatory effect as strongly as if you're treating a much larger volume of blood. When it comes to the laser probe, what you want to do is treat all the way around the joint, both anteriorly, as I'm showing here, posteriorly, and you also want to try and move the joint as best you can into abduction or flexion or extension and expose the joint capsule a little bit more, and then also do your probing. So in other words, I want you to move the shoulder joint in different positions while you're doing the laser probe, and this will facilitate a bit more light entering into the joint capsule itself. The probe should be held long enough to allow enough light to penetrate through the muscle tissue, the skin and muscle tissue, to enter the actual joint capsule. So you do have to try to modulate how long you hold the probe based on the amount of tissue you're trying to penetrate. So in other words, If you have a very muscular patient, you're going to have to hold the probe longer because you have to get through more dense tissue. If the patient is very petite or not as much muscle, then you don't need to hold the probe as long. So we usually recommend holding the probe for an average person maybe 10 seconds or thereabouts, but you may have to increase that 15 seconds or more for a very muscular person, or perhaps a little bit less for a patient that's very petite or not as well muscular developed. A few treatment gems or some tidbits of information. As I just mentioned, you want to treat around the entire joint capsule, both with the arrays and the laser probe. If the patient is presenting in significant pain, you can really lower the frequency. That seems to be the sensitive portion of treatment. So you can lower that below the standard protocol if you wish. The treatment time must reflect a therapeutic dose at the capsule level. That's just what I was trying to explain with the laser probe, is that you want to make sure that you have it on long enough to get enough light deep enough to have a therapeutic effect. Remember that if it's on too long, the therapeutic effect is actually diminished and won't be as good as if you get the optimal amount of light. So start off with a certain time and then work your way up to see if that improves your results. And as I mentioned already, you want to place the glenohumeral joint positions to increase exposure to the capsule, for example. Make sure you have realistic expectations, because obviously given the time frame involved for this different stages of frozen shoulder, it's not going to be something that's going to resolve in just a week or two of treatment. I do really highly recommend you add a red laser probe as well. Red laser is meant for superficial conditions, but it's also very effective for stimulating or blocking nociceptors while you're treating. Remember that the skin and the dermis has a large number of nociceptors that, of course, they're pain receptors, and by adding red light, you're increasing a huge amount of energy density in that area, and you can temporarily block pain by the dosaging from the red laser probe. So it is an effective tool for helping your patients get pain under control as well. Again, add manual therapy and exercises within patient tolerance levels, typically in the second and third stages. Don't forget to look at trigger points, both proximally and distal, that might be referring pain. And again, remember, you're stimulating fibroblasts that are going to be modulating collagen formation. This takes time to manifest as objective improvement by the patient. So you're not going to necessarily see a huge improvement in range of motion when you're dealing with fibrotic joint capsules right away. It's going to be a bit of a time element, but they definitely will start to improve as that scar tissue starts to resolve. I'd like to present a case study that a patient just presented this year, and she is a 57-year-old female chemist with a history of acute left shoulder pain for 6 months. She had a cortisone injection, and that actually aggravated her symptoms. She tried chiro, physio, and some analgesics, not helping a lot. Now, she did have a history of several minor injuries in and around the shoulder, which was interesting because if you think about the etiology, this may have been part of the problem. Her active range of motions were decreased by up to 80%. X-rays were normal. She did have an ultrasound, and that ultrasound did show a small partial thickness tear of her left supraspinatus portion of the rotator cuff. So we have a diagnosis of a torn rotator cuff, but also a history of multiple injuries to her left shoulder. All of this probably is what triggered the frozen shoulder. So she was considered in the stage 1 because of the amount of pain that she had coming in, as well, of course, as a tear of a rotator cuff. This is how we approached the initial protocol. You can see that we have 4 placements. As I mentioned, the 4th placement is the auxiliary placement. We did 5s and 6s, 5 minutes and 6 minutes, red and infrared, anterior, posterior, lateral, and auxiliary. The red light was continuous wave. We started at 20 hertz, 70% duty cycle. We cycled in the laser probe at 42% power, and we added the red probe to help with pain at 100%, both for about 9 minutes. That was a January 10th, her first visit. 4 treatments later, you can see in red, we start to modulate the red. This seems to have a better effect with respect to the red light. And we slightly increase frequency and the duty cycle as well. And we jumped the laser probe up to 100% as she could tolerate that as well. So that was the 4th treatment. Into the 6th treatment, Dr. Khan tried to be a bit more aggressive with the red light, taking it up to 1,000 to 90. Okay. So again, the high frequency, you can fool around with the frequencies. That has to do with the essentially trying to stimulate the superficial tissues and trying to get them to be a bit more active. Now, what he did, interesting enough, at the 10th treatment is he went from 1,000 back down to 100. So he found that by jumping to 1,000, the patient wasn't responding as well. So again, he took it back down to 100, increased the frequency of the infrared to 250. So right now, she's currently being treated at these parameters. Notice that we also increased the time, a bit more time with a laser probe. And she's currently responding quite well. I think she's at about 60% range of motion around there. Obviously, we're going to have to continue to treat her over a period of time, but she's progressing really well. I would say she's into that 2nd stage now and making fairly good progress. So that's just an example of how we might approach it. Remember that you're free to customize as you want, but don't be afraid to play around with frequencies, especially with the red. Typically, Dr. Khan will go from 190 either to 250/90 or 1000/90. And of course, we know with the infrared, we're going to go from anywhere from the starting dosages to 30/80, that kind of thing, and increase that as we go along. Okay, so newsflash, and that newsflash is this came out last week. So this came out by the American College of Physicians and Surgeons on clinical practice guidelines for the treatment of low back pain. Obviously a very, very common problem for a high percentage of the population. And these are guidelines specifically put out to general physicians on how to initiate treatment of low back pain. What was really interesting is this is the first time in the history of the American College of Physicians that they were not advocating the use of analgesics or injections for patients presenting with low back pain. What they were suggesting was the use of many other types of active therapies, including yoga, including Tai Chi, exercises, and they also talked about manipulation, massage, acupuncture, no other modalities except for heat and low-level laser therapy as well. So this article being read by physicians, they'll actually see low-level laser therapy in the guidelines. It's really important to emphasize this because if you have a rapport with family doctors or talk to physicians about referrals, they want to see evidence-based research. They want to see articles that relate directly to them as to why they should be doing this. And here is a great example of an updated, really like 2017, can't get more fresher than that, updated guidelines as to how they should be approaching low back pain. So really what the evidence is suggesting is physicians should make an immediate referral recommendation for active therapy and manual therapy and other types of treatments, including low-level laser therapy, and not just be taking out the prescription pad and prescribing, analgesics or opioids and all the rest of it. And we all know the dangers of that type of treatment. So I thought that was really good. This came out February 14th. I saw an article in the New York Times and then pulled up the article from the Annals of Internal Medicine. Okay, 2 weeks ago or 3 weeks ago, I was in California, San Diego for the annual NALT meeting. And I might even do a webinar on all the updated research. I thought it was really interesting, including research on Parkinson's, Alzheimer's, concussion, and all the rest of it. I think everyone out there would find this very interesting. So I'm hoping to do that over the next few weeks. But in the interim, I did want to talk a bit about my discussion and meeting up with Andrew Mester. He gave me permission to show a few of his slides. I actually took pictures of the slides as he was doing his presentation. And those of you who don't know, Andrew Mester is the son of Andre Mester, and Andre Mester is, or was, I'm sorry, a surgeon and physician from Hungary, and he is the one that's credited as to the actual discovery of low-level laser therapy, or what we know now as photobiomodulation. So he was given an award that night, and I wanted to present a bit about that. There he is on your right. I think this person over there is me next to him. So I now have my my picture next to the famous Andrew Mester. He spent a bit of time at our booth, and we talked to him a bit about our approach to laser therapy. He was quite impressed. So everyone probably has seen this picture before. These were the rats that were irradiated with red light back in the day. But what you may not have seen was an updated picture, or at least this picture he presented, that the rat on the right, well, let's back up a bit. The rat on the left was the one that was irradiated with red light and a certain dosage, and that dosage actually caused hair to grow back faster. Now, the same type of rat was also exposed to red light, and it was a much higher dosage. And you can see with the higher dosage, even though there was hair that grew back around the periphery, right where the dosage was applied, the hair did not grow back. So this is actually one of the first examples that show that if you overdose with light, the stimulatory effects are reduced. So here the hair grew back, here the hair did not grow back because the dosage was too high. Okay, so we know that you need to get the dosage correct in order to stimulate the cells. Okay, so those of you that are just learning about laser therapy, please understand that you need to start with lower dosages and see how patients respond. If you start too high, or if you use class 4, you're going to overstimulate the tissues more than likely, and the results as far as photobiomodulation will not be as good, or may in fact be inhibited. These are some examples of some of the patients that Andre Mester and Andrew as well. By the way, Andrew emigrated from Hungary to the United States, I believe in the 1980s, and before that he was actually practicing with his father in Budapest, Hungary, on many, many patients, including this one here showing a leg ulcer with tendon exposure that resolved with laser therapy. Again, another heel ulcer that resolved with laser therapy. So Andre Mester, he was board certified in surgery and radiology. He introduced intraoperative cholangiography, and he educated many medical students, had a very good reputation. He referred to all his students as my dear son, or perhaps daughter. I'm not sure if there are a few women in there, I'm sure. So he essentially invented laser biostimulation. And he worked tirelessly to help people that really had given up hope with respect to their cases. And he practiced medicine under the Hippocratic Oath to do no harm, which is very interesting because laser therapy, as you know, will not harm your patient. Here is a picture of his clinic and patients being treated with laser therapy in Hungary. This is in Budapest, Hungary. So it's quite interesting to see that. Andrew Mester told us stories of patients coming from all over Europe and Hungary to visit him in his clinic, and typically he would treat patients about twice a week. He stated that laser biostimulation has an effect on molecular and cellular levels, and of course he was way ahead of his time to understand this. That whole organ and tissue levels are affected. That's a systemic effect. It can help with the immune system, the circulatory system, and it is dose dependent. Okay, so with sufficient intensity, inhibition occurs, as I've already mentioned. That's really important to understand, and why we highly recommend that everyone get properly trained and not just open up a book or get a device and start to treat without having proper training. His philosophy was very admirable. First, to be a human being. Second, to be a physician. One of his quotes was, "Only a good person can be a good physician, and only a good physician can be a good surgeon." So yes, he was a very incredible surgeon, and really we owe a lot to Andre Mester and Anthony as well. Okay, so to finish off, those of you who haven't been trained by us, I just want to mention that we do have monthly certification trainings. You can register on our website, bioflexlaser.com. The next dates are, actually we have a training this weekend, and then March and so forth. We just came back from San Diego for a training, and we have a training coming up in 2 weeks in Calgary, and then Newfoundland, Vancouver, Virginia Beach, Montreal, and Red Deer for the balance of 2017. So hopefully you can make it out to one of our trainings. We'll also have a workshop, a masterclass, a one-day masterclass on May the 13th, and the title is Celebrating 25 plus years of clinical success. We have Dr. Khan, he's going to be doing a presentation, and also one of our most experienced and one of the largest laser therapy clinics out in North America is Ben Ewan, a chiropractor, along with his wife Elizabeth, a registered nurse in Halifax, or Bedford, sorry, Nova Scotia, just outside of Halifax, and Ben will be speaking on a couple of subjects, along with Andrea Dixon, Diva, our neurologist here in-house, Slava, of course, and I may even say a few words, Nicole and Stuart Carter, massage therapists, and we have some other speakers as well. So if you can make it, we'd like to see you. It's on a Saturday. Registration's at 8:30, and it goes from 9 to 4. Of course, there's CE credits. There's an early bird pricing in effect right now, so if you can save $100, I would get out there and register if you can, and it should be a really good event, especially hearing from Dr. Khan and going over some of his most interesting cases. The emphasis here is on clinical studies, or sorry, clinical case profiles and difficult and challenging cases that I think will be of great benefit for anyone that uses laser therapy and wants to learn how our experienced clinicians out there in the field approach these cases. Okay, so I'm going to pull up the questions and see if you guys have any questions here before I let you go. All right, well, it looks like we have lots of questions. Okay, I do have a question from Julie, and as far as the biggest challenge she's finding with these patients is that once they get to that 50 to 70% better range, how to achieve total resolution of the pain, especially the range of motion. You know, there is no easy answer for that. I think really what you have to definitely focus it on is your manual therapy in that second and third stage, and different techniques, and whether that's ART, you know, other ranges of motion exercises, that kind of thing. But, you know, I think for us, we do tend to modulate the light as much as possible. We try and get in there and treat the axillary region, both the probe and the array as well. And we try to be a bit aggressive with them. So I don't know if that is something you already do, Julie, or not, but it's definitely something that I think may be helpful as far as your approach to that. Let's just get into some other questions. What is the percentage specifically of spontaneous resolution over time? So the natural progression, my understanding of frozen shoulder is that they do eventually resolve, but you know, you're looking at anywhere from, you know, 9 to 12 months to up to 2 years or longer. So most cases do resolve, but sometimes they're left with difficulties even after 2 years. The problem is that if they don't have any treatment, the pathology is slower to progress. And I think definitely that's the case. If you don't add laser therapy, you're going to have a longer inflammatory phase and a longer phase of capsular fibrosing and scar tissue. So I'm thinking that if you add laser therapy, those you know, those stages will shorten. That's what I found with. I've been here for 7 years using laser therapy, and our other users that have been using it for longer than me, and of course in-house here, we've been finding that kind of result. Another question, repeat, Jane and Sharma, what recommendation for LLLT? So the recommendation, so I don't understand that question, Lori. Lori, you can always email me, just if you can ask me that question again. Oh, function up to 4 months into AC or 4 months of therapy at any stage. So oh, okay. You know what, Lori? They weren't specific about the stage there in that recommendation. I don't think so. I think that's what you're asking. Um, okay. How many times per week was that case study? 3 times a week. Although sometimes the patient's only getting in twice a week because it's hard for her to come out here. Is there a way to review this again? Again, if you want to watch this webinar again and you have our equipment, then you can go to our support page, which is password protected. If you don't have our equipment and you're interested in seeing it again and learning more, then you can contact us and we can send you a blind link. We do that once in a while if you're really nice. Just kidding. Can we get a copy of the study released in February? Yeah, that's available. I can get that out to you if you email me. That's from Evelyn. And is it worth to start, once again, someone is in the late stage in the evidence? Well, so as far as evidence for treating in the second and third stages, I'd have to look at that report again, but I'm pretty sure that they're referring to all the stages with respect to the research and offering evidence for laser therapy, Lori. But I can certainly look into that a little bit more, but I'm pretty sure it's not just the acute phase, it's the second and third stage as well, too. And a question from Shauna. Hello, Shauna. What if a client has chronic frozen shoulder, say 10 plus years, and will laser therapy help in that case? That's a long time to have frozen shoulder. I would say it still should be helpful, but man, I tell you, after 10 years, you're really starting to have a lot of chronic scar tissue. So I would think you'd have to be pretty aggressive with treatment and might have to put them back in an acute phase to see if you can get improvement with that. Sometimes they even do surgery, but that would be a last option for sure. Question from Amphi, is laser therapy still effective in the thawing stage with decreased pain, minimal pain, but increased joint stiffness? And how effective would LLL be? Yeah, again, so in the third stage, what you're dealing with there is you're trying to convert the fibrosing and the excessive scar tissue to more of a normal. So going from hyperplasia scenario to more of a normal status for the scar tissue. And that really has to do with collagen production. And there's a huge amount of evidence, maybe not so much specifically for frozen shoulder, but there's a huge amount of evidence on the effects of LLLT on fibrocytes and fibroblasts and tenocytes that modulate the production of collagen and help to improve the integrity of scar tissue. In other words, if you use light therapy, even on, say, keloid scars that are years old, you will reduce the keloid formation. So you're actually modulating that scar tissue to help to resolve. It may not resolve 100% for sure, but you can reduce it. And there's tons of research on that, so I would definitely say it would be helpful. But remember, if you can't get the light to the joint capsule, how effective are you going to be, right? So you need to make that a consideration as well. A question from James. I have a patient with frozen shoulder who has neurofibromatosis. Is laser contraindicated? No, it shouldn't be contraindicated for neurofibromatosis. I know there's settings that will not promote tumor growth. Okay, so sorry. I guess the thing with neurofibromatosis, if it's directly over the area, there's contraindication for an active growing metastasis or a cancer growth. Okay, so if there's active cancer growing in an area, you don't want to do laser therapy because we don't know if they're direct effects. If it's away from the area, then that's okay. And another question is, if a patient's had surgery which has not been effective, it's increasing mobility. If a patient has had surgery which was not effective in increasing mobility, would laser be effective? We do get cases where people have had surgery that wasn't effective. It's always challenged because what happens is the surgery tends to increase scar tissue even more, and that becomes a problem. Those patients are really chronic. They tend to require much longer treatment plans. In general, it should be helpful, but they have a poor prognosis. So, will it help? chances are it will help to some degree. I just don't know to what degree because of the chronicity, and after surgery you're dealing with even more scar tissue. Okay, thanks very much for joining everyone, and hopefully we look forward to seeing you next year or next month. And hopefully you guys can make it to our masterclass on May the 13th. Take care and have a great day.